4, 3, 2, 1. Disclaimer. I do not own the rights to the images or information provided. This was strictly made for the purpose of studying for boards. Lower motor neuron. The lower motor neuron, LMN, is the efferent neuron of the peripheral nervous system, PNS, that connects the central nervous system, CNS, with the muscle to be innervated. The entire function of the CNS is manifested through the lower motor neuron. The LMN includes two components. 1. The general somatic efferent system, GSE, and 2. The general visceral efferent system, GVE. The general somatic efferent system of the lower motor neuron includes the neurons that innervate striated voluntary skeletal muscle that is derived from somites and somatic mesoderm in the body walls, limb buds, and from semidomeres in the head. These neurons are located in all of the spinal nerves and all of the cranial nerves except I, and VIE. This chapter describes the spinal nerve GSE, LMN. Chapter 6 describes the GSE, LMN present in cranial nerves, spinal nerve, GSE, LMN. The neuronal cell bodies of this system are located in the ventral gray horns through the entire spinal cord. The shape and size of the ventral gray horn reflect the number of neurons present, which is determined by the volume of striated muscle that is innervated. The GSE neurons innervating the axial muscles populate the medial portion of the horn. Those innervating the appendicular muscles are located laterally and cause the lateral bulge of the ventral gray horn that is evident at the cervical and lumbosacral intumescences. Figure 5-1. These lateral portions of the ventral gray horn are subdivided further into metoniclear columns representative of muscle groups and the nerves present in the limbs. GSE neurons that innervate proximal limb muscles are located in the ventral portion of the lateral part of the ventral gray horn. Those innervating the more distal limb muscles are in the dorsal portion. These motonuclear columns have been identified by transecting nerves or ablating specific muscles and then observing in the spinal cord ventral gray horn the retrograde chromatolysis of the neuronal cell bodies whose axons were destroyed in the experimental procedure. The dendritic zone of the multipolar GSE neuron is confined to the gray matter of the spinal cord adjacent to the cell body of that neuron. The axon courses through the white matter between the lateral and ventral funiculi to leave the spinal cord as part of a ventral rootlet. It continues in a ventral root and then into the spinal nerve, to which the root contributes. Then it travels into the limbs as part of a specific named nerve that is distributed to a specific group of striated skeletal muscles. Figure 5-2. The part of the axon that is located within the spinal cord, intraparenchymal, is myelinated by oligodendroglial cells, whereas the part of the axon located within the PNS is myelinated by Schwann cells. Note on terminology, a nerve consists of a collection of axons in the PNS myelinated by Schwann cells and encased in various layers of connective tissue, that is, endoneurium, perineurium, and epineurium. No nerves exist in the CNS, all nerves are components of the PNS, so, the word peripheral nerve is redundant. At the level of the striated skeletal muscle, each axon of a GSE neuron divides into several branches. Each of these axonal branches ends on a muscle cell at a motor end plate. Each adult muscle cell is innervated only by the axon of one motor neuron. In the fetus and newborn, more than one neuron may innervate a striated muscle cell, but during early postnatal development this polyneuronal innervation is reduced to a single neuron. The number of muscle cells innervated by one GSE neuron is called the motor unit. It varies from 100 to 150 muscle cells in the proximal limb muscles to 3 to 4 in extraocular muscles. Muscles involved in functions that require a large degree of coordination are innervated by motor neurons with small motor units, only a few muscle cells per neuron. The strength of a muscle contraction depends on the number of motor units activated in a muscle. At the motor end plate, the myelin sheath is absent, and the axon terminates in several small branches that form a cluster in a localized area near the longitudinal center of the muscle cell. Each of the small branches terminates on a specialized modification of the sarcolemma. This terminal is called a neuromuscular ending, junction, or synapse. Figure 5-3. The neuromuscular junction consists of a distended axonal terminal covered by a Schwann cell that has not formed myelin up to the point where the axon extends into a sarcoplasmic trough on the surface of the muscle cell. The endoneurium of the nerve and the endomysium of the muscle cell are continuous outside this trough. Inside the trough, the axolemma and sarcolemma juxtaposed, the axon terminal contains numerous mitochondria and synaptic vesicles, the latter the source of the neurotransmitter substance acetylcholine. The sarcoplasmic trough is located on an area of the muscle cell membrane at which the sarcoplasm has accumulated. This is called the soul plate and abounds with muscle cell nuclei and mitochondria. The surface area of the sarcoplasmic trough is further increased by invaginations of the sarcoplasm to form postsynaptic membrane folds, subneural clefts. The synaptic cleft is the space between the presynaptic membrane, axolemma, and the postsynaptic membrane, sarcolemma, and is about 200 angstroms, A-ring, wide. The postsynaptic membrane abounds with nicotinic acetylcholine receptors. These receptors consist of 5 subunits formed from the integral proteins of the cell membrane and arranged in a circular shape that forms a channel for sodium ions. When the action potential traveling along the axon arrives at the neuronal presynaptic membrane, calcium channels on the axolemmal surface open. The increase in exoplasmal calcium triggers the release of acetylcholine from the synaptic vesicles into the synaptic cleft, where the acetylcholine molecules bind to the receptors in the sarcolemma of the soul plate. This binding opens the sodium channels and the influx of sodium results in depolarization of the soul plate region. If enough channels are opened, the depolarization spreads, resulting in muscle cell contraction. The acetylcholine released into the synaptic cleft is rapidly eliminated by diffusion away from the cleft site and by hydrolysis by acetylcholinesterase that is released into the cleft through the muscle cell membrane. Spinal cord segments. Vertebral column. For clinical purposes, it is important to know in which spinal cord segments the neuronal cell bodies of the GSE motor neurons are located, whose axons are in specific nerves, and to know the specific vertebrae, vertebral foramen, in which these segments are found. For example, if the neurologic examination of a medium-sized dog determines that the patient has a deficit localized to the sciatic nerve innervation of the pelvic limb, the anatomic diagnosis includes all components of that nerve as well as the neuronal cell bodies in the L6, L7, and S1 spinal cord segments. These spinal cord segments are usually located in the L4 and L5 vertebral foramina, and their spinal nerves course quadrantally in the vertebral canal to lead through the intervertebral foramina between vertebrae L6 and L7, L7 and S1, and S1 and S2. In the dog, the spinal cord is composed of about 36 segments, 8 cervical, 13 thoracic, 7 lumbar, 3 sacral, and usually 5 caudal. Each segment has a number of dorsal and ventral rootlets that attach, respectively, to the dorsolateral and ventrolateral aspects of each side of the spinal cord. The segmental spinal ganglion is found in the dorsal root just prior to its union with the ventral root at the level of the intervertebral foramen. The spinal nerve emerges from the intervertebral foramen and immediately branches into a dorsal and a ventral branch. Thus, each spinal cord segment is connected to the tissues of the body by a spinal nerve on each side. The dorsal branch innervates epaxial tissues and the ventral branch innervates hypaxal tissues, which include the limbs. The development in the embryo of the spinal cord segments and that of the vertebral column are closely related, which accounts for the manner in which the roots and spinal nerves of each segment are distributed among the vertebrae. The first cervical spinal nerves leave the vertebral canal through the lateral vertebral foramina in the arch of the atlas, figure 5-4. All the remaining spinal nerves leave the canal between vertebrae via intervertebral foramina or the sacral foramina. This is also true for the cat. Other species have a variable number of vertebrae with lateral vertebral foramina which accommodate the passage of the spinal nerves. The spinal nerves of the second through the seventh cervical spinal cord segments leave the canal through the intervertebral foramina cranial to the vertebra of the same number. Therefore, the seventh cervical spinal nerves leave the vertebral canal cranial to the C7 vertebrae. See figure 5-4. Because only 7 cervical vertebrae and 8 cervical spinal cord segments exist, the spinal nerves of the 8th cervical spinal cord segment leave the vertebral canal cranial to the first thoracic vertebra. All the remaining spinal nerves leave the vertebral canal through the intervertebral foramina that are caudal to the vertebrae of the same number. Thus, the first thoracic spinal nerve leaves the vertebral canal caudal to the T1 vertebra. This segmental relationship of the spinal cord and vertebral column is established in the embryo. After birth, as the animal grows, more growth occurs in the vertebral column than in the spinal cord. This alters the relationship of the spinal cord segments to the vertebrae, resulting in a cranial displacement of most of the spinal cord segments in relation to the vertebrae. In the dog, only the first and second cervical spinal cord segments and the last 2 thoracic and first 2 or 3 lumbar segments lie in the vertebral canal within the vertebral foramina of the same numbers. All the remaining segments reside in the canal cranial to the vertebrae of the same number. To accommodate for this cranial displacement, the spinal nerves must lengthen because the place where they exit the vertebral canal cannot be altered. This is especially evident in the caudal, lumbar and sacral vertebrae, where the arrangement of the long spinal roots and nerves adjacent and caudal to the conus medullaris is called a caudoequina for its resemblance to the tail of a horse. See table 4-1 in the discussion in chapter 4, where the positions of the sacral segments within the vertebral canal are described. This cranial displacement of the caudal, lumbar, sacral, and caudal segments is most apparent in the large dog breeds, in which the 3 sacral segments are located in the 4th lumbar vertebra. In all dogs and cats, the only nervous system tissue in the vertebral foramen of L7 is the collection of spinal nerves passing caudally to their respective intervertebral or sacral foramina to leave the vertebral canal. Table 5-1 and figure 5-5. Function. The GSE portion of the LMN provides the fine motor innervation of the muscles whose contractions are necessary to maintain posture, support weight, and provide the gait. They are also the motor component of the spinal reflexes that are tested in the neurologic examination. Knowledge of the anatomy of these reflexes is critical to localizing lesions to portions of the PNS or the spinal cord. The sensory components of these reflexes are neurons of the general somatic afferent, XA, and general proprioceptive, GP, systems. These systems are described in chapter 9. These sensory neurons consist of a dendritic zone, receptor, in the skin or neuromuscular spindle, and an axon that courses through a specific named nerve, spinal nerve, and dorsal root and enters the spinal cord dorsal gray horn of the corresponding spinal cord segment. Here, it usually terminates in a telodendron on a dendritic zone of a second neuron, whose cell body is located in the dorsal gray horn. Figure 5-6. The cell body of the XA or GP neuron initially stimulated is located in the spinal ganglion of the lateral aspect of the dorsal root. The patellar reflex, see figure 5-6, is a tendon reflex that is composed of only 2 neurons. It is a monosynaptic reflex arc. The sensory neuron terminates directly on the GSE neuron in the ventral gray horn without involving a synapse on a second neuron, interneuron, in the gray horn. The peripheral sensory neuron of the flexor, or withdrawal spinal reflex, has its telodendron on an interneuron in the dorsal gray horn, which, in turn, terminates on a GSE neuron in the ventral gray horn. For these spinal reflexes to function, they need only the nerve components and their associated spinal cord segments. They will still function when these segments have been cut off and isolated from the rest of the CNS. For example, if you examine a dog 2 days after a motor vehicle accident that fractured the 13th thoracic vertebra and transected the 13th spinal cord segment, the spinal reflexes in the pelvic limbs and perineal region would still function because no direct disturbance occurred to the spinal cord segments and nerves involved with these reflexes. To interpret these spinal reflexes properly, it is vital to understand their anatomic components. Table 5-2. This is critical to making an accurate anatomic diagnosis of nerve and spinal cord disorders. Pelvic limb and perineal reflexes. The lumbosacral plexus innervates the muscles that are involved with pelvic limb movement in the cutaneous region of the pelvic limb. 58. The sacral plexus innervates the muscles and skin of the perineal region. The lumbosacral plexus is widespread, with most of it located in the hypaxal muscles associated with the lumbar and sacral vertebrae. In most animals, it includes ventral branches of all the lumbar and sacral nerves. Most of the named nerves are formed and the hypaxal muscles are close to them. The pelvic limb spinal reflexes test the femoral nerve and the sciatic nerve with its fibular, peroneal, and tibial nerve branches. Nav. 2005. Fibular is preferred to peroneal for the name of this nerve and muscles. The patellar tendon reflex is the only reliable tendon reflex and the only one that I AD test in my examinations. Both the sensory and motor components are in the femoral nerve. The femoral nerve is formed from the spinal nerves of the L4, L5, and L6 spinal cord segments, figure 5-7. The L5 segment makes the largest contribution to this nerve. 147. The L6 segment may not contribute to this nerve in some dogs. The patient should ideally be held in lateral recumbency and must be relaxed. This reflex cannot be tested in a struggling patient. Lightly strike the patellar tendon with a blunt instrument. A pediatric patellar hammer or pleximeter is the most satisfactory instrument for veterinarians, but the handle of a pair of scissors will work as well. In my experience, e.g., the pediatric pleximeter is especially useful in cats and small dogs, but a larger pleximeter or heavy bandage scissors may be more reliable in large dogs such as German Shepherd dogs. This will elicit a brief extension of the stifle if all components of the femoral nerve are functioning. We usually grade the response as normal, +2, depressed, +1, or brisk, +3. The response is called clonus if, with one stimulation, repetitive stifle extensions occur. The paw will appear to tremor. Degrees of clonus exist, but we do not find them to be of much help in prognosis. In most animals, the patellar reflex is evaluated in the non-recumbent limb. Occasionally, the patellar reflex will not be present in the non-recumbent limb but will be present when the dog is rolled over and you test the reflex when the limb is on the recumbent side. We do not know the reason for this but have learned never to record that the reflex is absent until it has been tested in both positions. In some very anxious patients, this reflex may be evaluated with the animal in the standing position by elevating the limb off the ground with the stifle and coxofemoral joints slightly flexed. Be aware that this reflex may be depressed or even absent in some old dogs that have no other recognizable neurologic abnormality. The flexor or withdrawal reflex in the pelvic limb is a test primarily for the sciatic nerve and its spinal cord segments L6, L7, and S1. Within the sciatic nerve, the neurons that will be associated with the fibular nerve tend to be components of the L6 and L7 spinal cord segments, and those associated with the tibial nerve are components of the L7 and S1 segments. The S2 components primarily innervate muscles in the pelvis that do not participate in this test or in the animal's postural gait. The sensory component of the reflex depends on the area of skin that is stimulated. In a routine examination, the skin at the base of the claw of the fifth digit is compressed by using a pair of forceps. Finger pressure may be used but is not always sufficient, in our experience. In addition, hemostats apply a more consistent pressure between different patients. This area of skin is innervated by cutaneous branches of the fibular nerve dorsally and by the tibial nerve on the plantar surface. The motor response is a flexion of all the joints in the limb to withdraw the limb from the stimulus, except for the hip. Flexion of the pelvic limb is a function of the GSC components of the sciatic nerve. The major flexor muscle of the hip is the iliopsoas, which is innervated by all the lumbar spinal nerve ventral branches, with a contribution quadrantally from the femoral nerve. The latter also innervates the rectus femoris, which is the one component of the quadriceps muscle that flexes the hip. Because of this anatomy, a patient with complete sciatic nerve dysfunction will have no reflex or nociception if the fifth digit is compressed, but if the first digit is compressed, the hip will flex to pull the limb away from the stimulus, but the rest of the joints will not flex. The first digit usually receives its cutaneous innervation from the saphenous nerve branch of the femoral nerve. It is important to look for this disparity. The same strong hip flexion in the absence of any flexion in the other joints will occur with severe but not complete sciatic nerve dysfunction when the fifth digit is compressed. As a rule, there is more clinical evidence of loss of motor function with some preservation of sensory function in a partially compressed nerve. The flexor reflex is not only a test of the reflex arc that utilizes the sciatic nerve, it is also a test for nociception, which requires the sensory portion of the nerves involved with the reflex plus a pathway through the spinal cord and brainstem to the neocortex. This is described with exosystem in Chapter 9. Because of this nociceptive pathway, you must be gentle with the degree of compression of the digit that you use, or you may rightfully be abused by your patient. Other muscle and tendon reflexes that are used by some neurologists and myself, e.g., include the gastrocnemius reflex in which, with the tarsus slightly flexed, the common calcanean tendon is lightly tapped with a pleximeter or blunt instrument. In the normal animal, this elicits a slight extension of the tarsus. This is a test for the tibial nerve branch of the sciatic nerve. When you perform this tendon reflex, you may also observe a brief twitch of the caudal thigh muscles, which suggests that this monosynaptic reflex has spread in the spinal cord to involve other branches of the sciatic nerve. The craniocrural muscle reflex is elicited by lightly tapping on these muscles with the tarsus held in slight extension and observing a slight flexion of the tarsus. This is a test of the fibular nerve branch of the sciatic nerve. My AD concern is that I am not convinced that these muscle tendon reflexes can be elicited in all normal dogs. Therefore, I rely on the features of the patient's posture and gait to differentiate between a tibial and fibular nerve deficit. Additionally, in very nervous dogs, even light striking with the plex R is enough for the entire limb to react, making interpretation of these reflexes difficult. In general, these reflexes are more significant when they are present than when they are absent. The perineal reflex is a test of the branches from the sacral plexus that is located in the pelvic canal. These branches supply the external sphincter muscle of the anus, the striated muscles of the penis, vulva, and vestibule, the urethralis muscle, and the skin of the anus, perineum, and caudal thigh. It is not necessary to learn the names of the specific nerve branches or their individual areas of innervation. Mild compression of the skin of the perineum or anus with forceps will elicit an immediate contraction of the anal sphincter and flexion of the tail. The latter response requires that the caudal spinal cord segments and nerves be intact. Thoracic limb reflexes as a rule, we rely only on the flexor withdrawal reflex in the thoracic limb. In reality, it is a crude test of many anatomic components. The cutaneous sensory component depends on the area of skin that is stimulated by compression. These areas are more accurately defined in Chapter 9 with exosystem. Compression of the lateral digit stimulates primarily the cutaneous endings of branches from the ulnar nerve dorsally and from the ulnar and median nerves on the palmar surface. The muscles that contract to flex the joints and withdraw the limb are innervated by the GSE, LMN systems present in many nerves. For shoulder flexion, it is primarily the axillary, radial, and thoracodorsal nerves. For elbow flexion, it is primarily the musculocutaneous nerve. For carpal and digital flexion, it is primarily the median and ulnar nerves. These nerves have their central components in the cervical intumescence, which includes the spinal cord segments, C5, C6, C7, C8, T1, and T2. The ventral branches of the spinal nerves from these segments intertwine medial to the shoulder to form the brachial plexus from which the specific named nerves emerge. Figure 5-8. For example, the musculocutaneous nerve, which is responsible for the elbow flexion, contains primarily branches from spinal nerves and segments C6, C7, and C8. All of these components must be intact for the withdrawal reflex to be normal. Remember that, as in the pelvic limb, the stimulus used is a noxious stimulus that tests the nociceptive pathway as well as the flexor reflex. Always start with a gentle compression. Utilization of hemostats is the perfect tool for this purpose. 3 tendon muscle reflexes are used by some neurologists, but the reliability of these reflexes may be questioned. For the biceps reflex, hold the elbow in partial extension with your first finger on the distal bellies of the biceps brachii and brachialis muscles. Lightly tap your finger with your pleximeter or some other blunt instrument and observe for a slight flexion of the elbow or feel the muscles contract beneath your finger. This is a test for the musculocutaneous nerve in the C6 and C7, C8 spinal cord segments. For the triceps reflex, hold the elbow relaxed in slight flexion and lightly tap the triceps tendon just proximal to the olecranon tuber and observe for a slight elbow extension. This tests for the radial nerve in spinal cord segments C7, C8, and T1. For the extensor carpi radialis reflex, hold the thoracic limb so that the carpus is relaxed. Lightly tap the proximal belly of this muscle and observe for carpal extension. This tests the extension of the radial nerve into the interbrachium by its deep branch. The presence of these tendon muscle reflexes indicates that the nervous system components involved are able to function. Their absence may be of no consequence because these reflexes are not always present in all normal animals. The cutaneous truncee reflex involves a larger portion of the spinal cord. Figure 5-9. It is useful for locating C8 and T1 spinal cord lesions and their contributions to the lateral thoracic nerve, and it is also useful for locating the level of a transverse thoracolumbar spinal cord lesion. The sensory stimulus is a mild compression of the skin of the trunk using forceps, and the motor response is a brief contraction of the cutaneous truncee muscle, which causes the skin of the trunk to twitch bilaterally. This reflex is usually performed using progressive stimuli starting in the caudal lumbar region and progressing cranially along the dorsal midline of the trunk. The cutaneous nerves that are stimulated are from the dorsal branches of the lumbar and thoracic spinal nerves. See figure 5-9. The sensory impulse courses through the dorsal roots and enters the dorsal gray column of each respective spinal cord segment. Here, the axons of axoneurons synapse on long interneurons whose axons enter the fasciculus proprius on both sides of the spinal cord but predominantly the contralateral side. The fasciculus proprius is the white matter of the lateral funiculus that is adjacent to the gray matter. These axons course cranially to the T1 and C8 spinal cord segments where they terminate in the ventral gray column by synapse. In on GSC neurons whose axons emerge from the brachial plexus as a component of the lateral thoracic nerve that innervates the cutaneous truncee muscle. Any disorder that interrupts this pathway will interfere with this reflex. On rare occasions, this reflex cannot be elicited in a normal dog. Sometimes, it takes rigorous stimulation to elicit it. In normal dogs, how far caudally in the lumbar region the reflex can be stimulated varies. Most will show the reflex by the middle of the lumbar region. Its use in locating the level of a transverse spinal cord lesion is described with spinal cord disorders. E.g., often test both sides of the trunk for this reflex rather than only on the midline. This is particularly helpful in cases such as brachial plexus injuries and unilateral fibrocartilaginous embolic myelopathy of the cervical intumescence. Lower motor neuron disease, neuromuscular disease clinical signs. The terms LMN disease and neuromuscular disease, NMD, are used interchangeably. The latter term includes the muscle as well as the LMN because the clinical signs are very similar. Disorders of any part of the GSE, LMN system will cause muscle paresis or paralysis, along with hyporeflexia or arflexia, hypotonia or atonia, and neurogenic atrophy. Normal muscle tone is dependent on a closely regulated, constant stimulation by the LMN that innervates the striated muscles. The LMN forms the motor component of the spinal reflexes. The dictionary definition of paresis is weakness. The student tends to interpret this to mean loss of muscle strength with loss of tone and difficulty supporting weight, which correctly characterizes the paresis caused by LMN disease. However, in medicine, 2 qualities of paresis are described. When severe, both forms may result in complete paralysis and inability to move, but the quality of the paralysis is very different in the 2 forms. These 2 forms are LMN and oculomotor neuron, paresis or paralysis. The word paralysis should be used only with complete absence of any voluntary movement. LMN paresis is described in this chapter. Paresis is described with the anatomy of that system in chapter 8. The 2 forms are compared in that chapter. Neurologists define paresis as a deficiency in the generous scion of the gait or in the ability to support weight. The lack of ability to support weight characterizes LMN paresis. If the patient is ambulatory, the gait will include short strides and will appear as a lameness. The gait in LMN disease is identical to that of an animal that has discomfort when the diseased limb attempts to support weight. The inability to support weight looks the same as when an animal expresses pain whenever weight is supported. Animals with LMN disease walk as you would with a stone in your shoe. The stride is shortened. Consequently, it is important to rule out any orthopedic disorder in your evaluation of an animal with LMN disease by doing a complete orthopedic examination. When you see a shortened stride in the gait, always ask yourself if it is because the patient is unable to support its weight or is unwilling to support its weight because of discomfort. If multiple limbs are affected by LMN disease, the animal will tend to collapse and have difficulty standing up from a recumbent position. When both pelvic limbs are affected by LMN disease, the animal may walk by simultaneously flexing both hips to advance the limbs. This is referred to as bunny hopping. Be aware that animals with pelvic or pelvic limb orthopedic disease with discomfort may also bunny hop to avoid painful movements. When standing, the affected limbs may exhibit a tremor in the muscles, and the affected animal may continually shift its weight from one limb to another and look for an opportunity to lie down. This is especially evident in horses with diffuse LMN disease. An animal with diffuse LMN disease that is still ambulatory may stumble on uneven surfaces. This state is often often confused with ataxia, which implies a sensory system abnormality, a general proprioceptive or vestibular system disorder. LMN disease does not cause ataxia, only paresis. An animal with only an LMN disorder knows exactly where its paws or hooves are located because the sensory systems that convey cutaneous and proprioceptive informa shine to the CNS are unaffected. The major problem is support and degree of limb advancement, which results in the short hind stride. When evaluating an abnormal gait, also ask yourself the following question: does this animal know where its limbs are located? The patient with LMN disease knows their locations and therefore moves the paw or hoof very rapidly when it attempts to move the limb. When the GP system is affected, this knowledge is lost and a delay occurs in the limb movement. Loss of function also causes a delay in the initiation of limb movement. Postural reactions are complex, and they require that multiple components of the CNS and PNS, including the LMN, be intact. Many postural reactions are described, but the most useful is the animal's ability to hop on each limb. To evaluate these reactions correctly, it is important to practice eliciting them. The patient must be reasonably cooperative. So what can be done about a fractious dog or cat that fights any restraint? The answer is simply that the tests are not performed and instead whatever manipulations the patient will allow are relied upon. First, make friends with your patient. Use the animal's name. Tell the patient what you are going to do. This may sound foolish, but you have to gain the trust of the animal. It is much better to do this examination without the presence of the owner, who tends to distract the attention of the patient. Also, many owners do not understand what you are doing and are liable to get upset. You also should perform this examination on a surface that provides some grip for the patient. A carpet is the best surface, in my experience AD. This is critical for the interpretation of mild abnormalities. One that can be hosed off is advisable because often the patient will excrete on it. To test the hopping responses, stand over the patient facing in the same direction as the patient and keep scratching those ears. Place one of your forearms beneath the patient's abdomen and lift the pelvic limbs just free of the ground surface. If you rest your elbow on your thigh, you can avoid stress to your back. With your other forearm, pick up the patient's thoracic limb on that side and move the patient in the direction of the supporting limb. As you look down that limb and slowly move the patient toward it, as soon as the paw disappears beneath the shoulder, the animal should hop. Get 3 or 4 hops and then shift your hands. Pick up the limb that just hopped, and move the patient toward the supporting limb until you get 3 or 4 hops on that limb. Keep repeating this until you are comfortable that these are normal hopping responses or that there's an abnormality. Always evaluate the limb as you make it hop laterally. You should not have to move at all during this test. For the pelvic limbs, stand beside your patient. Place your forelimb that is nearest the patient's head beneath its neck and between its thoracic limbs. Lift the patient's thorax and thoracic limbs off the ground. With your other forelimb, pick up the patient's pelvic limb that is on your side and push the patient away from you so that it has to hop on the opposite pelvic limb. Change sides and repeat this in the opposite limb. The pelvic limbs normally do not hop as fast as the thoracic limbs. In very large dogs that are too heavy to lift, these hopping actions can be performed by hammer walking your patient. Stand beside the patient, pick up both of his limbs on one side, slowly push the dog away from you, and watch the hopping responses in the limbs on the opposite side. Remember to compare one thoracic limb with the other and then one pelvic limb with the other. In patients that have LMN disease and are still able to stand and walk, the hopping responses will be as fast as normal if you help them support their weight. With all their weight supported on one limb without your assistance, the patient will collapse or have difficulty trying to hop without collapsing. The attempts are brisk because their proprioception is unaffected. For the paw or hoof replacement reaction, stand over or beside the patient. Turn the paw or hoof over and place its dorsal surface on the ground. Usually, the normal patient will immediately replace the paw or hoof onto its palmar or plantar surface. As long as the patient with LMN disease has enough strength to move its joints, this response will be normal. The patient with severe paralysis that is unable to move its limbs will obviously be unable to replace its paws from this abnormal position. Like other postural reactions, this paw or hoof replacement reaction requires that multiple CNS and PNS pathways be intact, that is, the GP, XA, and LMN systems. It is inappropriate to refer to this paw or hoof replacement test as a test for conscious proprioception, CP, because of the involvement of the other neuroanatomic systems in the response. This anatomically incorrect and misleading term is deeply embedded in the vocabulary of the veterinarian but should be expunged. No test for just conscious proprioception is available. Severe diffuse LMN disease produces the same degree of paralysis as a severe focal mid-cervical spinal cord lesion. Recumbent immobile patients appear to be the same as each other. The first clue that they are very different will be when you attempt to pick the patient off the ground surface. The patient with diffuse LMN disease will be atonic and just hang limply over your forearms. When you lift the patient up and set it down, the limbs will flop uselessly. This is flaccid paralysis. When all 4 limbs are affected, it is referred to as tetraplegia or quadriplegia. Thus, a patient with severe diffuse LMN disease has flaccid tetraplegia. A patient with a severe focal cervical spinal cord lesion will be paralyzed in recumbency because of the loss of function in its some pathways, resulting in the inability to generate any LMN function and releasing the reflex arcs from inhibition. The latter results in hypertonia that is referred to as spasticity. This will be obvious when you attempt to pick up the recumbent animal. All the muscles will feel taut, giving the trunk and limbs a remarkably stiff feeling. This will be especially obvious as you lift the patient up and down or try to flex any of the limbs. This is spastic paralysis of all 4 limbs, or spastic tetraplegia. Video 10-24, see Chapter 10, shows 2 dogs that make it easy to appreciate the comparison. The patient with a severe diffuse LMN disease described earlier will have no tone in the limbs when they are manipulated, that is, atonia, and no patellar tendon or flexor reflexes, that is, areflexia. The latter reflex requires a noxious stimulus, and many diffuse LMN diseases do not affect the XA pathways, therefore, nociception may be intact. The only evidence of nociception will be jaw and facial movements and an increase in the rate of respirations because any voice sounds may be absent or muffled. Animals that are recumbent because of LMN disease but still have some voluntary movements may exhibit hypotonia and depressed spinal reflexes. In the diffuse LMN disease known as as myasthenia gravis. The recumbent animal may still have normal tone and normal spinal reflexes. The patient that has diffuse LMN disease and is still able to ambulate, albeit in short strides, may have reduced muscle tone and reflexes, or they may be normal. Remember to examine the muscle tone and reflexes in the anus, perineum, and tail because they will be affected with sacrocaudal LMN disorders. Denervation of muscles occurs when the LMN of the muscle is unable to function. The loss of axonal impulses results in a rapid degeneration of the denervated muscle. It is referred to as denervation or neurogenic atrophy. It is rapid and severe. It may be first observed in a muscle group about 7 days after the denervation. The health of the muscle cell is dependent on its constant innervation. Without that innervation, the muscle cell rapidly loses protein, and after many weeks the cell will die and be replaced by fat and fibrous tissue. The rate and degree of denervation atrophy varies with the species and the specific muscle that is denervated. Denervated muscles may be severely atrophic for weeks and still return to normal size when reinnervated. This is especially evident in dogs with severe acute polyradiculoneuritis, Kuhnhund paralysis, an immune-mediated disease that affects primarily the LMN. Disuse atrophy is usually much slower to develop and less severe than denervation atrophy. This occurs in limbs that are immobile when placed in a cast, or in a limb with a chronic joint disorder that causes discomfort when the limb is used and therefore results in a decrease in the use of the limb. An example of this occurs in rapidly growing, very active retrievers that develop a painful osteochondrosis lesion in the shoulder, resulting in significant disuse atrophy of the lateral scapular muscles. These muscles are especially prone to disuse atrophy that is severe enough to mimic a suprascapular nerve disorder. Remember that when you make the anatomic diagnosis of an LMN disorder, whether it is a focal or a diffuse abnormality, you must consider all components of the LMN for the lesion site, because the same LMN signs will occur whether the lesion is in the spinal cord and is affecting the neuronal cell bodies of the LMN, or is in the axons in the ventral roots. Spinal nerves, ventral branches of the spinal nerves, the plexus these form, or the named specific nerve that terminates at the affected muscle or the neuromuscular junction. And do not forget that the lesion may be in the muscle itself. As a general rule, the dysfunction caused by the loss of function of a named nerve exceeds that caused by the loss of function of an entire ventral root or spinal nerve. This is because the named nerve supplies the entire innervation to the muscle it innervates, whereas a single ventral root or spinal nerve contributes the axons of a few neurons to many named nerves and their muscles, but not to the entire innervation of a muscle. For example, the C7 spinal nerve contributes elements to the suprascapular, subscapular, musculocutaneous, axillary, and radial nerves, but it is not the only source of elements to any of these nerves. Therefore, a radial nerve lesion causes a much more severe clinical deficit than a C7 spinal nerve lesion. Wallerian degeneration is an important concept that is useful in mapping the anatomic components of nerves and spinal cord segments, in recognizing peripheral or CNS disorders microscopically, and in understanding and predicting reinnervation by nerves. When a nerve axon is destroyed at some point in its course away from the cell body, it will completely degenerate from the point of destruction to the structure innervated. This is because the axon requires the axoplasmic flow of cytoplasmic materials from the cell body for its survival. Dr. Augustus Waller, 1816-1870, described this degeneration of neurons within nerves, hence its designation as Wallerian degeneration. Although not part of Waller's study, the same process occurs in neurons within the CNS, where it is useful for the recognition and location of lesions. Wallerian degeneration is a trophic degeneration that occurs in the neuron at the site of a lesion and travels in a distal direction from the cell body as follows. Figure 5-10. The axon degenerates through a process of swelling and subsequent granulation that takes about 3 to 4 days. The myelin degenerates simultaneously with the axons. A close interaction exists between the axon and its myelin, and myelin cannot survive if the axon degenerates. This is a secondary demyelination. In this process of Wallerian degeneration, this secondary demyelination includes the formation of swellings along the internodes, called ellipsoids, and the fragmentation of myelin into droplets. Digestion chamber is a term used for a myelin ellipsoid containing axonal granules. The telodendron and motor end plate disintegrate. The Schwann cells that are now reduced to their nuclei and cytoplasmic organelles rapidly proliferate to form a column of cells known as a Bungner band. The adjacent endoneurial cells also proliferate. These columns of Schwann cells provide pathways for regenerating axons to follow to the target that was denervated. They also provide growth factors that induce the outgrowth of axonal buds from the proximal portion of the neuron where the axon is still intact. This regeneration begins in about 7 days. Each axon puts out a number of processes called axonal buds, which grow into the existing cores of proliferating Schwann cells. The rate of growth is about 1 to 4 millimeters per day. This process is dependent on close proximity of the axonal buds and the Bungner bands. With this knowledge, you can estimate for the owner of a patient that has a nerve injury how long it will take for some evidence of regeneration to occur by measuring the distance from the site of a lesion to the middle of the denervated muscles. Using the slowest rate, 1 mm/day, the distance in millimeters is the same as the number of days. When a nerve has been completely severed, it is important to suture the contents together to provide the least impediment to this effort to regenerate. If an impediment such as hemorrhage or fibrosis prevents the axonal buds from reaching the nearest bands of Schwann cells, the axonal buds will continue to grow in a haphazard manner and form an observable swelling known as a neuroma. These neuromas may be a source of considerable discomfort. They are often a sequel to the neurectomies that are performed in the distal extremities of the horse to eliminate a source of discomfort such as a degeneration of the distal sesamoid bone, referred to as navicular disease. The resultant neuroma may then be an additional source of irritation to the patient. Along with the changes that occur in the neuron distal to the lesion, other changes occur proximal to the lesion. If the lesion is an injury, the trauma will produce degeneration of a few internodes proximal to the lesion in a manner similar to the trophic degeneration that occurs distal to the lesion. A reaction occurs in the cell body in the spinal cord, called the axonal reaction, in which a slight swelling of the cell body, a displacement of the nucleus to one side of the cytoplasm, an eccentric nucleus, and a disbursement of the granular endoplasmic reticulum of the nissl substance within the cytoplasm occur. The last event is referred to as central chromatolysis and represents the efforts of the cell body to produce more products for the axoplasmic flow necessary for the regeneration to progress. This central chromatolysis has been used in the anatomic mapping of the components of the ventral gray horns in the spinal cord and the LMN nuclei in the brainstem. Electrodiagnostic techniques in neuromuscular disease. The most common electrodiagnostic techniques used in veterinary medicine are electromyography, EMG, and the determination of conduction times. EMG is the study of the electric activity of muscle by inserting a recording electrode into the muscle and observing the electric activity with the aid of an amplifier on an oscilloscope. An audible signal accompanies this recording. It is used clinically to determine whether the LMN, its myelin, or the muscle fibers themselves are the site of a lesion. Like any ancillary procedure, it is used to confirm and more precisely locate a clinical observation of a neuromuscular disorder, and it may contribute to the prognosis. Normal resting muscle shows no or very limited electric activity on EMG once the electrode placement has been stabilized and audible signal is absent. This is the resting potential associated with the muscle being studied. In LMN axonal disease, muscle cells become denervated. About 5 days after denervation in the patient, continuous spontaneous potentials called fibrillations develop. They have amplitudes of less than 200 microvolts. They are biphasic or triphasic, last 1 to 2 milliseconds, msec, fewer than 7 millisecond, and produce a sound like eggs frying. They may occur as often as 2 to 30 times per second. They represent the spontaneous action potential or contraction of an individual denervated muscle cell that cannot be seen through the skin surface of the patient. Denervation disturbs the metabolism of the muscle cell and makes it sensitive to circulating acetylcholine, which makes it contract spontaneously. The prevalence of fibrillations in denervated muscle may decrease after 3 weeks. Positive sharp waves, potentials, may also accompany the fibrillations recorded in a denervated muscle cell. They are characterized by an initial low voltage, sharp positive deflection, and a slow return to the baseline. Voltage is variable, ranging from 50 to 1000. The positive sharp waves usually last several times longer than the fibrillations, and they have a dull sound. Spontaneous contraction of an entire motor unit, called a muscle fasciculation, may be visible on the surface of the patient. It varies from 300 to 2000 in amplitude and lasts 4 to 10 milliseconds. Fasciculations occur in LMN disease and occasionally are seen in normal muscle. As a general rule, the fibrillations and positive sharp waves that occur with denervation imply a dysfunction of the axon, whereas a severe myelin disorder is more likely to be reflected in impairment in the rate of impulse transmission, and motor nerve conduction will be slowed. Motor nerve conduction may be determined using much of the same equipment that was used for the EMG study. In this study, a motor nerve will be stimulated, and the evoked muscle potential is observed on the oscilloscope. In the thoracic limb, this is usually performed using the ulnar nerve, which may be stimulated at the brachial plexus, in the elbow, and in the carpal canal while recording the evoked response from the interosseous muscles. By measuring the distance between the two stimulating electrodes, the conduction time can be measured in meters per second, ms. In the pelvic limb, the tibial nerve is stimulated at the level of the greater trochanter of the femur, stifle and proximal to the tarsus, and the responses are recorded from the interosseous muscles. Other motor nerves in the muscles they innervate can be used. Normal conduction times are dependent on age and temperature. They vary from 50 to 60 ms. Nerves that have been injured and avulsed and have undergone Wallerian degeneration for 4 to 5 days will not conduct impulses. Decreased conduction velocities usually occur in nerves after severe loss of their myelin sheaths. The evoked potential resulting from motor nerve stimulation is the summated motor unit potential recorded on the oscilloscope. Normally, it is a smooth B or triphasic wave that lasts 5 to 10 milliseconds and varies in amplitude but is often greater than 3000. The amplitude of the evoked potential is proportional to the number or integrity of the axons that innervate the muscle. In LMN disease, the evoked potential may be polyphasic, with a reduced amplitude, and prolonged if some nerve fibers are conducting slowly. Loss of some motor units prevents the smooth summation of response. In myositis, if the inflammation involves the neuromuscular junctions, denervation potentials may occur in an EMG study. Polyphasic potentials of decreased amplitude may be observed in motor nerve conduction studies in patients with myositis. These electrodiagnostic studies are useful for confirming a neuromuscular anatomic diagnosis but may be less useful for distinguishing between an LMN and a muscle cell disorder. Another use of an EMG study is to elicit a form of myotonia that implicates a disorder of the muscle cell membrane. Myotonia is defined as the continuous contraction of muscle cells that persists after the stimulation or voluntary effort is stopped. In the EMG study, it is stimulated by the needle insertion and appears as a repetitive high-frequency discharge that initially increases in amplitude and frequency and then decreases over 4 to 5 seconds. This produces an audible and distinct sound that waxes and wanes and is described as the sound of a dive bomber or a dirt bike. This is referred to as true myotonia. Another form, called pseudomyotonia or complex repetitive discharges, has an abrupt onset when the muscle first contracts. After a few seconds, it abruptly stops. Both forms result from a hyperexcitable muscle cell membrane. Although myotonic bursts may occur in many muscle cell disorders, the most common diffuse myotonias are inherited and are seen in young animals or accompany hypertonicorticoidism in older dogs. Myotonia is described further in Chapter 20 and is illustrated by videos. Sensory nerve conduction velocity may also be recorded by stimulating a sensory nerve distally and recording the response at some proximal point in the same nerve. As a rule, the superficial branches of the radial nerve in the interbrachium are used in the thoracic limb and the superficial fibular nerve is used in the pelvic limb. For more details on these studies, other textbooks should be consulted. Neuromuscular disease, diseases of the GSE, LMN and MD is defined as a disorder of the entire GSE, LMN and the muscle cells that it innervates. These diseases include those that affect any part of the entire motor unit, the cell bodies in the CNS, the axons and their myelin sheaths in the spinal and cranial nerve roots, the spinal and cranial nerves in their entire peripheral distribution, the neuromuscular junctions, the striated skeletal muscle, and the striated visceral muscles of the larynx, pharynx, and esophagus that are innervated by GSE, LMNs. The following case examples of LMN disorders are organized as they would be considered in a differential diagnosis for a patient, in which a specific anatomic diagnosis has been made involving its LMN. In this text, only the most salient features of these disorders are described, and rare considerations are excluded. More detailed information may be found in other veterinary neurology texts.